Infectious diseases of the heart. Endocarditis. Infection of the interlining of the heart characterized by endocardium inflammation. This occurs when bacteria in the bloodstream colonize a heart valve or other damaged tissue in the heart and they begin to multiply. Highest risk in patients with mitral or aortic valve disease, prosthetic heart valves, congenital heart disease, right-sided endocarditis, affects the tricuspid and pulmonary valves, IV drug users, patients with infected central venous catheters, dialysis shunts, or transvenous pacing wires. Virulence, reflected by the severity of the patient's illness, mild, gradual symptoms, low-grade fever, severe, serious illness over days to weeks, high-grade fever. Assessment, we have symptoms which would include fever, chills, headache, loss of appetite, weight loss, muscle and joint aches, pains, night sweats, shortness of breath, cough, heart failure, Janeway lesions. Don't know what that is. Osler nodes. Don't know what that is either. EKG changes may be seen, including a prolonged PRI interval. Third degree AV block or left bundle branch block. It's a lot. That's a wide degree of changes. Management care is supportive. This allows the patient to assume positions of comfort, establish an IV line, apply cardiac monitor, apply pulse oximeter, administer oxygen if indicated. If the patient has heart failure, follow the local protocol and medical direction. Treatment, we're going to give antibiotics, surgery, severe cases. If it is left untreated, then we might have valve prolapse. We could have valvular regurgitation. I think I have some of that. Pericarditis, an inflammation of the pericardium caused by either a viral, most common bacterial, or occasional fungal infection. In many cases, no cause can be identified. This is idiopathic pericarditis. Assessment, ask the patient about recent flu-like symptoms and symptoms, flu-like signs and symptoms. Patients may relate a history of recent upper respiratory infection. Chest discomfort is the most common symptom of pericarditis. Could have a sharp stabbing pain that is made worse by deep inspiration, coughing, or lying flat. Pain decreases when sitting up and forward. Listening to the heart sound may reveal pericardial friction rub. This is a sign that is not always present. These signs include pale skin, jugular vein distension, ST segment elevation in multiple ECG lines, normal breath sounds, unless other conditions exist. Management, pre-hospital care is supportive. Allow the patient to assume a position of comfort. Establish the IV line. Apply a cardiac monitor. Apply a pulse monitor. Administer oxygen. And obtain a 12-lead EKG. Transport with lights and sirens. Or siren. Transport with lights or siren. Transport with lights and sirens. Why does it say or? Treatment, pericarditis. We're going to treat with non-steroidal anti-inflammatory drugs. What is it called? Solumedrol. Viral pericarditis usually resolves on its own. Non-steroidal. Solumedrol is steroidal. So non-steroidal is anti-inflammatory. NSAIDs. We'll come back to that. Bacterial pericarditis treated with antibiotics. Fungal pericarditis is treated with antifungal medications. Myocarditis, inflammation of the myocardium, usually benign and self-limiting. If untreated, it will impair the heart's ability to pump and may result in right ventricular failure, left ventricular failure, dysrhythmia, death, dilated cardiomyopathy, and can be caused by viruses, parasites, bacteria. Rheumatic fever can lead down to that. Exposure to chemical poisons, alcoholism, radiation therapy, unknown factors. Assessment. Most cases are associated with flu-like symptoms for which the patient does not seek care. Symptoms like these, they could include fatigue, decreased appetite, mild hoarseness of breath, joint muscle aches and pains, fever, palpitation, chest discomfort, and often a sharp stabbing pain in the center of the chest. Could have tachycardia, could have tachypnea. Atrial ventricular dysrhythmia, right bundle branch block, left. There's so many of these. This is literally like everything that could be wrong with the heart. Crackles, ascites, peripheral edema, heart failure is present. The EKG may show low voltage QRST complexes and or ST segment elevation. Differential diagnosis to consider for myocarditis includes ACS, aortic dissection, esophageal perforation, rupture, tear, heart failure, Kawasaki disease, pneumonia, pulmonary disease. Management, we have a pre-hospital care, which is supportive. Allow the patient to assume a position of comfort, establish an IV line, apply a cardiac monitor, apply a pulse monitor, and administer oxygen. Obtain a 12-lead EKG and treat the heart failure and dysrhythmia according to local protocol or instruction from medical direction. Rheumatic fever. Inflammatory disease. This is caused by streptococcal bacteria. So if you have strep and it gets bad enough, it doesn't just stay there, right? It spreads. It's a disease. It can spread to the heart. Rheumatic fever. Causes mitral valve stenosis leading to heart complications. Supported pre-hospital care. Scarlet fever. Scarlet fever is caused by Streptococcus pyogenes. We're going to say pyogenes. Bacterium. Signs and symptoms include sore throat, fever, rash, strawberry tongue. I saw a picture of that on Instagram on one of the medical pages I follow. Patients younger than 1 year are greatest at risk, and treatment includes antibiotic supported pre-hospital care. Scarlet fever. Vascular disorders. Aortic aneurysm. This is terrible. An aneurysm is the dilation or outpouching of a blood vessel in the wall or chamber of the heart. Of the greatest concern of those that involve aorta, such as acute dissecting aneurysm of the aorta, ADA. Do not want that. You will lose more blood than you can compensate. Pathophysiology may begin with a tear in the inner lining of the aorta, the intima, near the weakened portion of the vessel. The blood flows through the tear and between the layer of the vessel wall, exposing the middle layer of the blood under high pressure. Blood fills the space between the layer of the vessel, causing them to separate or dissect. With each ventricular systole, the blood is forced into the torn arterial wall, creating a false channel between the intimal and medial layer of the wall. If the dissection goes back to the aortic valve, it may not be able to close. Blood will regurgitate into the left ventricle during systole. If the dissection involves a takeoff point to the innominate left common carotid or left subclavian artery, the blood flows through the affected arteries will be diminished. Most begin with the ascending aorta within 2 inches, 5 centimeters of the aortic valve, and the descending thoracic aorta at the site of the ligaments. And I feel like without having a picture, like this is useless. It's in one of my other slides, sessions. Arteries lose elasticity prematurely by atherosclerosis is the most common, high blood cholesterol, hypertension, and CHD, congestive heart disease. Medial degeneration. Aneurysms of the ascending thoracic aorta are usually caused by cystic medial degeneration, a connective tissue disease in which the normal elastic tissue is replaced with cystic connective tissues. A mild form is often present in the aortas of older adults, may be a natural consequence of aging. In younger people, it is accompanied by Marfan syndrome. Don't know what that is. Congenital problems, trauma, syphilis, infective endocarditis, and other infections. I need to make a note of like things to go back to, like Marfan. What was it? Marfan syndrome. Yep, it's not even up there. Signs and symptoms depend on the location. So we have pressure of a large amount of blood on the surrounding organs that may produce symptoms. The patient's description of the pain provides clues to the location of the dissection. Almost all patients report an abrupt onset, constant, unbearable pain. Ascending aorta dissections usually associated with pain that is either substernal or located in the neck, throat, jaw, or face. Descending aortic dissection usually produces flank pain. Pain between the shoulder blades, and pain in the back of the abdomen or lower extremities. May be difficult to distinguish chest pain of a dissecting aneurysm from that of a acute myocardial infarction, but a number of distinctive features may differentiate it. So if we have onset pain all of a sudden, if it's gradual, so it's a slow build of pain, that's when you know it's a myocardial infarction. It took time to kill that tissue. But if it's abrupt without prodromal symptoms, aortic aneurysm. Severity of the pain, so it increases with time, again, gradual. Maximum from the moment it happens, like being stabbed. May wax and wane, timing of pain, so it kind of like ebbs and flows. Does not abate once it's started, it sucks. Location of the pain, substernal back is rarely involved. However, the back is often involved between the shoulder blades if it is an aortic aneurysm. Clinical signs, peripheral pulses are equal, blood pressure discrepancy between the arms, and decrease in the femoral or carotid pulse. So you're gonna have, yeah, this is like more peaceful. This is a peaceful heart attack compared to a dissecting aortic aneurysm. You may not live. Symptoms include anxiousness, feeling of impending doom. This is still ADA. Pain, weakness, numbness, tingling of extremities. Signs, myocardial ischemia, heart failure, altered mental status, stroke, paraplegia, cardiac arrest, sudden death, and syncope. Ascending aorta dissections can occur in younger patients previously in good health. One or more vessel of the aortic arch is compromised. Pressure differences between 20 millimeters Hg between the arms may indicate that the presence of the aortic aneurysm. Suspect dissection if this finding is accompanied by acute neurological changes. May show signs and symptoms of stroke. EKG changes characteristics of myocardial ischemia. May occur when the dissection extends proximal to the coronary ostia. Descending aorta dissections are more common in older patients, especially with those who have a history of hypertension. So pain is less severe than ascending aorta dissections, and distal pulses may be hard to feel. Rupture of the thoracic aneurysm may occur, and signs of hemothorax may present if the dissection ruptures into the pleural cavity. Signs of cardiac tamponade may be present if the dissection ruptures into the pericardial cavity. Rupture of the abdominal aortic aneurysm may also occur and will ordinarily be associated with sudden back pain, accompanied by abdominal back pain and tenderness. The patient might be hypotensive, and pulsating abdominal masses between the xiphoid process and the umbilicus may present. Sensitive to palpation, may be quite tender, and abdominal distension usually occurs. So for management, we are going to establish an IV line. We're going to apply a cardiac monitor, apply pulse ox, administer oxygen, give IV fluids, medications per local protocol, or medical direction, administer opioids if patient's blood pressure can tolerate it. Do not delay transport. Nothing can be done to stabilize the patient's condition in the field. Patient requires aggressive therapy in an intensive care unit and possibly surgery. Stop there.